Okay, in that case, the pleasant duty of introducing our next speaker, Dr. Rajeev Reddy Pappuru, falls upon me. Welcome you, Dr. Rajeev, for your talk on retinal detachment and PVA.
Okay. So, thanks for inviting me to share my experience and doing retinal detachment surgeries with proliferative retinopathy. And I'm just going to show some of the videos where I have done a few of the proliferative retinopathy detachments. So, and in that process, I'll just give a few of my experiences and what helped me in doing this. There is no one way of getting these things done. There are multiple ways, and each one has their own way. And I would say what makes these detachments different than what we usually do a simple rhegmatogenous retinal detachment is presence of membranes and contraction of the retina. So these are the two things which makes it sets them apart from a regular retinal detachments, which tackled well would give you a better results when compared to not tackling these two properly. So this video is actually showing you where I'm trying to open the funnel. That's the first thing which you do if you have a closed funnel adding. So where you go to the center of the funnel and try to dissect it there and then make an opening. Once you do that, then you will get a cleavage where you can actually go inside and start slowly dissecting to open the funnel completely. That's one tip which I would say that don't make a break in the periphery to start with, but go try to open it in the center of the funnel. So which will give you a proper plane for you to dissect it out, and you may be injecting a little bit of a PFCL into that opening, and that starts opening up the funnel, and then start peeling the membranes well. So that's one thing which I would say help you in dealing with proliferative retinopathy with the closed funnel detachments. So the next one is dealing with membranes. When you say proliferative retinopathy, membranes is implied. And we see a lot of membranes where they can be seen clearly, like what you see here. So I would always start with posterior to anterior dissection of membranes. So one advantage when compared to diabetic membranes in these cases, there is usually not a vascularized membrane, so it's relatively easier for you to peel it off when compared to diabetic membranes, where peeling is not that easy because they are stuck to the retina with the vasculation, so you have to cut them. But these ones, if you get a correct hold of it and then try to peel it off, always do tangential peel. Don't pull it up to the center of the vitreous cavity. Hold the membrane and try to peel along the retinal surface to the periphery, which will help you to peel off the membrane more completely than going and picking it up multiple. Like you see that I'm not pulling towards the vitreous cavity, I'm going towards the periphery. So that's what removes the membrane more easily than pulling it up towards the vitreous cavity, which might cut off the membrane. Then again, you have to go back and hold the membrane again. So that's a thing which you should always remember when you are doing a membrane peeling in these cases. So one more point which we need to remember whenever we're doing a membrane peeling in pre-retinal membranes is this, that's presence of an anterior PVR. So most of the times, this is the ciliary body area which we are seeing here, where retina is pulled up with an anterior membrane, and it's that causing the retina to get stuck to the ciliary body. So dissecting these membranes are important in two ways. One is if you don't identify this membrane and try to settle the retina, so though you have removed most of the membranes posteriorly, retina looks clean, but we will not be able to settle the retina because retina is pulled up in one area. So we will start causing subretinal air, which you start when you start settling the retina, causing tears in the retina when you try to forcefully try to attach the retina there. Second thing is identifying and removing this part will help you in managing the hypotony post-operatively in these cases, which is seen more often, mainly because these peripheral membranes will cause damage to the ciliary body and causing a long-term hypotony, and we will not be able to remove the oil from these patients. And then ultimately, you might end up attaching the retina by cutting the retina in the periphery, but you will not be able to salvage much in this because of the hypotonia, which is a sets in and continues for a long time. So that's important to identify the anterior PVR. So that's the second pearl, I would say, that identifying this and removing it to the extent possible is important. The third thing is identifying the subretinal membranes. So you see that subretinal membranes are seen in most of the PVR cases. One thing which we need to remember is it is not necessary to remove all the subretinal membranes when you want to settle the retina. But at the same time, if there is need for subretinal band removal, it's important to do it, and you may have to make a retinotomy in an area where you can actually easily access these membranes. That's identifying the site of where you're going to make a retinotomy in these patients is important. So that's what is shown in this video. So I made a retinotomy there and the left side where the membrane was seen there, which is causing the retina to be stiff there. So that's what we identified, and we have removed all the pre-retinal membranes. I was trying to peel from the opposite side. So I was finding it difficult to hold. So I went from the same sclerotomy. So that's what actually gives you better access to that membrane. And you can hold the membrane and try to gently pull it off. You don't have to do any forceful action. Most of the times it comes off. Sometimes you may have to roll it off so that it comes out easily well. So the moment you remove that, you can see the retina has become flapping there. So that means the retina has got released. So that's an identification which gives you that, yes, that a membrane peeling for subretinal is good enough for you to settle the retina in there. You go after the subretinal membrane even if it is not causing much of a pull on the retina in cases where it actually going through the macula, which might result in decrease in vision post-operatively. So that's the cases where even if it's not causing the retina to tent up, you might still end up going and removing those membranes, like what you see here. So we could have settled this retina even without it, but then if you see this, there is a band which is going right through the macula area. To leave that there like that, you might be able to settle the retina, but then visual prognosis in this case will not be that good. So that's the reason why we made a retinotomy here, and then again, and go inside and try to pull that membrane. Gently pull it off, but if you try to pull forcefully, sometimes you might even create a retinal break in posteriorly. And we need to be careful when you are trying to, this is what I was talking about, rolling off the membrane. If you don't take precaution while you're doing it, you might actually accidentally pull the retina into the membrane there and try to cause more tear than what it is, what you could have managed without it. The gentle pull, not a forceful pull, is something which you should always look at. So that's something which we should always remember when you're dealing with the subretinal membranes. So we dealt with the pre-retinal membranes, anterior proliferation, subretinal membranes. So you removed off all the membranes what you could practically possible. So now then you're left with a retina which you should be able to settle off easily. But what happens is this is a case of trauma with corneal scar, and then we're trying to settle the retina, removed off all the membranes. But once you have removed off all the membranes, when you try to look at whether you can still settle the retina, you see the retinal folds which are still fixed, and that's something which might not let you settle the retina. So I do a diathermy, especially to the larger blood vessels, and you connect it with cutter. So you, what we call as postal stamp retinectomy, where you just make multiple holes in the retina using a diathermy and then connect it all through. And always make sure that you don't cause too much of a bleeding when you're cutting this. So that's the one thing which you should always remember when you're doing a retinectomy. So another tip about doing retinectomy is when you try to settle the retina, you use it a low pressure, air pressure at a lower level rather than using it at 25, 30. I use it somewhere around 15 to 20. so that when you are doing the fluid air exchange, the retina is not forced back onto the choroid, that where it can cause tear in the retina. So if the pressure is low, what happens is what we have seen here. So when you're trying to settle the retina, where see the arrow mark there, the air slowly starts going below, and you see the retina is still stiff there. It's not going back. So that means the retina is contracted and will not go back. So that's where you can actually go there and extend the retinotomy a little more, so that you can actually settle the retina without causing much problem, without causing a tear. So there's controlled retinal attachment, and extending the retinotomy where is required is important. So another thing which we should always remember when you are doing a retinectomies is, so once you do a retinectomy, you might be able to settle the retina, but while managing the anterior flap is another thing which is very important. If we don't remove the anterior flap, this tends to roll up and goes towards the ciliary body and causes fibrous proliferation. It can result in neovascular proliferation in the periphery, sometimes even cause ciliary body pull and hypotony, resulting in anterior PVR. Though the retina is attached well and causing, it would still cause a long-term hypotony or sometimes neovascularization of the iris, because the retina in the periphery, which is cut and left around, is going to cause proliferation of tissue there. So that's another thing which you should always remember when you are doing membrane retinectomies in these cases in the proliferative retinopathy. So other than that, settling the retina, once you have done that, is quite simple. So in short, tackling the membranes and releasing the contracted retina and putting the retina back in position are the main things which will differentiate a proliferative retinopathy from regular ecmotogenous detachment without a proliferative retinopathy. Thank you.
Thank you so much, Dr. Rajeev. Really lovely videos, and you simplified the topic by dividing it into its various steps very nicely. Just a few questions if you have time. Any role of or in your pre-operative assessment, when would you decide to use a belt buckle encerclage in these patients, or when would you avoid it?
Encerclage is when I see one thing is whenever I see a pediatric cases with a proliferative retinopathy, I would definitely try to put encerclage, mainly because I might not be able to get the complete PVD to the periphery, and I might not be able to dissect off membranes that easily. And if I see too extensive membranes and feel expected a contracted retina in it, then I might not put the encerclage in those cases, mainly because I know that most likely I might end up doing a retinectomy, so there's no point in putting an encerclage in these cases.
Fantastic. If any of the other moderators have a quick question, then we can take that.
Yeah, I would like to ask you, Dr. Pappuru, how extensive you manage to do the retinectomy if you have too much of subretinal strand like that. If it's too large, isn't it better off to do retinotomy, very peripheral retinotomy, to put the retina down with PFO?
Yes, subretinal bands never make me do a large retinectomies actually. So like what I was showing, I just make a retinotomy there locally and try to remove all the subretinal bands, and you might be able to settle the retina most of the times. The reason why I will do an extensive retinectomy is because of internal contraction of the retina rather than a membranes. So that's what I was talking about. An incomplete membrane peel should not be an indication for a retinectomy. Yet I would say you have removed all the membranes, and then you may have to consider doing retinectomy.
Thank you so much, Dr. Pappuru, for that wonderful presentation. We'll move on to our next speaker. It's my